I am assistant professor. I am assistant professor in AIIMS Raibareli, and very warm welcome to the 18th webinar of Academy of Pain Physiatrists. And today we are going to study about the role of botulinum toxin in the chronic pain management. So today's it is a unique mechanism. The botulinum toxin A has a unique mechanism of action and modulate nociceptive pathways, reducing peripheral sensitization. And understanding when, where, and how to use the botulinum toxin A can significantly enhance the clinical outcome, reduce pharmacological burden, and improve overall rehabilitation trajectories. So that is exactly why today session is very important and for of all of us in PMR. And today we have among us Dr. Mohit Kishore Srivastava, who is presently the assistant professor in VMMC and Safdarjung Hospital in Department of PMR. And he's also my post-graduate batchmate. So I am very, very obliged to be a moderator of this session. And I also want you all to know that he is the first made in India DM pain specialist who is MD PMR. He has done his MDM pain from AIIMS Rishikesh. And he's also completed his certified course in essential of pain and essential in palliative care and fellowship in, he's also a fellow in pain management. So all of these illustrate his deep commitment to the excellence in the international pain practice. So now I invite with great respect and enthusiasm my colleague, Dr. Mohit Kishore Srivastava to begin today's session on the role of botulinum toxin in chronic pain. Dr. Mohit, platform is all yours.
Thank you, Dr. Satyasheel, for such a warm introduction. I'll be sharing my slides. First of all, my slides are visible.
Yes, your slides are visible. You can start, sir.
Thank you. Okay. Thank you, Dr. Satyasheel. A very warm welcome to all of you. Thank you for joining us today. I'm Dr. Mohit Kishore Srivastava. I am assistant professor in the Department of PMR, VMMC, Safdarjung Hospitals. And today we will be discussing on this topic. I thank all the organizers for giving me an opportunity to speak on such an important topic, such an important molecule that can be used and is widely used in the field of pain medicine. So, very brief introduction about the history of the molecule. It began in 1980s that the Botox was first used for ophthalmologic conditions like strabismus and dystonia. In the 90s, then its direct analgesic effects came into role, that how actually the Botox acts in the field of pain medicine. Then more and more RCTs were done in the field of Botox, using it in the field of pain medicine. For example, shoulder pain, the cervical dystonia pain, the pelvic pain syndromes, and the myofascial pain syndromes. And it was the landmark year of 2010 that the FDA gave its approval for using Botox in the condition of chronic migraine, which was a major milestone in the field of pain medicine. And from the last 15 years, various ultrasound as well as the EMG guided injections have come into role for management of pain using Botox. So this is a very common question that comes in all our mind, that why Botox in pain medicine? What was actually the need when we have so many molecules to deal with pain? So there are two main reasons. The burden of chronic pain is so much that we have to keep things in our armamentarium to manage chronic pain. And secondly, there are some limitations of using oral medications. So we can see both of these conditions one by one. If we talk about most common chronic pain conditions like the shoulder pain, the neck pain, and the migraine, it has a wide prevalence. The global prevalence is actually that much that we need things to cure it. It has a considerable disability that affects people. It reduces the functioning, that reduces the quality of life, and the years lived with disability is considerably more when it comes to shoulder pain. The same burden happens when the patient suffers from chronic neck pain. The global prevalence is around 203 million people are estimated at this point of time having neck pain. Similarly, the years lived with disability is around 244, which is quite a lot when it comes to neck pains. And lastly, the burden of migraine, a lot of global incidence and a lot of years lost with disability. So the burden is that much that we need some molecules to take care of that besides the usual medications. The second reason is mostly the limitations of the oral medications. So what we have already have in dealing pain is the actually somebody has their mic on. I think they can mute it. We have various limitations of oral medications. For example, various systemic adverse effects are there of NSAIDs. They are nephrotoxic. Paracetamol is hepatotoxic, and if we use the adjuvants for managing pain like gabapentinoids, pregabalins, they have their side effects of sedation, cognitive slowing, as well as the metabolic side effects. If we talk per se about migraine, prophylaxis deals with using beta blockers, but have their effects on causing bradycardia. Asthma is one thing you have to take care of while prescribing beta blockers, and the beta blocker induced fatigue is a different thing to deal with. So many patients discontinue these drugs because of these side effects. The second reason is the polypharmacy issues, right? When we prescribe medications in patients of pain, they already are hypertensive or diabetic or maybe facing other issues. So we can't just keep on adding our drugs. So we need something to target at the local site and get the relief for pain for that person. Third reason is the tolerance, dependence, that what happens with opioids and muscle relaxants. And so they are usually not recommended when it comes about chronic migraine or chronic musculoskeletal pain. For in cases of migraine, medication overuse headache is one of the diagnoses that we should always take care. When the person is using the NSAIDs to terminate the acute attack more than 15 days a month, that may itself lead to medication overuse headache. So here the Botox can play some role. Finally, limited efficacy in many patients. We have seen in our OPD practice that many of our patients with cervical pain, with shoulder pain, do stop responding at all with these medications or with the therapies that we prescribe. So here the role of Botox can be very path breaking if we use it in these conditions as well. So chronic migraine, the cervical dystonia, or it's better known as the focal spasticity, and the refractory pains, whether it be a myofascial pain syndrome, a myofascial cervical pain syndrome, a myofascial lumbar pain syndrome, the role of Botox becomes appropriate. These are the top three molecules that we have in our hand to manage the chronic pain. We are very well versed with using Botox, or the Onabot that we know as it is. The second is the Incobot, that is the Xeomin, and third is the Abobot, that is the Dysport. All the three are the variants of type A botulinum toxin. When we talk about the conversion factor, if we want to convert Botox to Dysport, we have 1:3 ratio. If we want to convert Botox to Xeomin, we have 1:1 ratio. So incobotulinum toxin is actually a very good molecule, very purer molecule than Botox. But guidelines, we'll see what guidelines say about using Botox in these conditions. Prabotulinum is not in this part of the world, but it is very increasingly used in the Western regions. So the basic questions that comes in our mind, that why neurotoxin? What does it actually causes? We, the physiatrists, are very well versed with using Botox in conditions like spasticity, but that is not the end of the story. We can use Botox for pain. We can use Botox for managing dystonia. That is a fact. What is its mechanism of action? It produces localized chemodenervation. That is, reduces the muscle hyperactivity. It reduces spasms. It reduces abnormal contraction, and thereby minimizes the systemic exposure of the oral medications. And as Dr. Satyasheel also told in the introduction, it has a very dual pain modulating mechanism as well. That is, it acts on the peripheral sensitization by inhibiting the release of various neurotransmitters like substance P, CGRP, and the glutamate. So when the peripheral sensitization is reduced, then in turn, indirectly, it also reduces the central sensitization. So when we have a lesser spark, then the spinal cord amplifies it lesser. So that is a key driver when it comes to chronic pain management. We know about the Botox kinetics as well, that its onset occurs in 3 to 4 days. The maximum effect is seen in 2 weeks, and the effect lasts up to 3 months. So less frequent dosing is required. That is a very good advantage over the daily oral drug dosing. But that we should always remember that Botox always act because of its cumulative effect. It's not that we once we administer Botox and the patient will be relieved with pain later every time. It's not that. We need to repeat our Botox doses for the patients. Improves adherence as well as patient satisfaction, and increasing uptake as health system is shifting more towards the non-opioid chronic pain strategies. These are the research areas. Still not very much research is available, but osteoarthritis, knee, post-surgical pain syndromes, pelvic pain syndromes are some of the research areas in which Botox is increasingly being used nowadays. It's a safer and a targeted drug to be used. So this is what FDA has. Connection is fine. Can you hear Dr. Satyasheel and other?
Yes.
We can hear.
Okay. So this was what the FDA actually told about, and the European guidelines came about using Botox. They clearly said that initiate Botox with some molecule that has a lower immunogenicity. So ideally, it is the lower immunogenic molecule is the Xeomin actually, because it's much purer, it's lighter molecule. But if you are using Botox as the initiation therapy of your appropriate choice, that depends on the clinician what he or she wants to use. And finally, recognizing the signs of clinical resistance as we increase dosing, and the frequency is of higher significance. So where the Botox stands, does Botox is Botox a first line management? Never. It is a second line management. It is plays a secondary role when it comes about managing chronic pain with multimodal pain management and enhancing the functional rehabilitation. So this is what the postgraduates get into about managing pain and managing spasticity. So there are basic differences I am pointing out in this table, that when managing pain, it is anti-nociceptive, it is anti-inflammatory. You can target muscles, you can target perineurally, you can intervene you can give your Botox in the fascial planes as well. You will have to deal with smaller doses, but the evidence is not as strong as compared to spasticity. In case of spasticity, the mechanism is totally neuromuscular block. It targets only the spastic muscles. Much higher doses are required, and a very strong evidence is available when we talk about spasticity. So this is a basic difference when using Botox in these two conditions. I'm not going into details about the structure of Botox. We all know that it's composed of a light and the heavy chain bound by a disulfide bond. When the bond breaks, the lighter chain cleaves the SNAP25. It inhibits the endocytosis phenomenon, and in turn inhibits the release of the neurotransmitters into the cleft, and thereby reduction of peripheral sensitization by reduction of neuropeptides, as well as the central modulation mechanism. These were the type of Botox that were available. I reposted this table again because I wanted to point out the strength of the vial that is available when it comes to Botox. So when you're using OnaBot, then you have 100 unit vials, you have a 200 unit vials. You can make in 2 ml, make in 4 ml. Ultimately, in 0.1 ml, you will get a 5 unit of Botox, and you can keep it in the lower part of your refrigerator at 2 to 8 degrees Celsius up to 24 hours. But if you are keeping it much higher in a very colder environment, you can use it for several weeks as well. So the dose that you can go for is 400 unit. You always have to reconstitute with preservative-free 0.9% normal saline and have to use it within 24 hours. The vial strength varies when you shift to Dysport, when you shift to Xeomin, or I personally don't have any experiences using a toxin B, that is the myoblock. So a bit about preparation tips. We already know we have been using Botox since ages nowadays. We reconstitute it with 0.9% normal saline. The Botox vial it looks like this. It is totally empty vial. It's vacuum dried. If you get a negative sign for vacuum, immediately discard the vial. There's no point using the vial when you don't have a vacuum preserved in it. We mix the solution very gently. We don't do a vigorous shaking in that case. And then we preserve and use it within the 24 hours if you're keeping it at 2 to 8 degrees Celsius. We talk about the injection techniques that many of us are interested in actually today. Anatomical or the palpatory method is available. If we target the superficial muscles, I think many of us are very well versed with our anatomy, and we can give Botox that way. EMG and ultrasound are good ways to target exact or to get exact localization of your muscles, in which the ultrasound is much more preferred, and we can go for EMG also if we are targeting very deep muscles with trigger points. Always reconfirm muscles with contraction. This is actually a difference when you use Botox and when you use steroid, right? Botox creates a functional weakness. So you don't want to give Botox inadvertently into the surrounding muscles. Now we shift to the indications in pain medicine where the Botox is usually used. I have marked out or chalked out some of the not that common indication. The first is like that only. Cervical dystonia with neck and shoulder pain. Many of us are seeing chronic neck pain, chronic shoulder pain, and we just forget that it may be a postural thing, it may be a dystonic thing that the patient is suffering with. So here your Botox can help. Limb dystonia is another indication, FDA approved indications. Myofascial pain syndrome of the neck and the lower back, we will discuss it later. Then chronic migraine is FDA approved indication of using Botox. It's very commonly used, especially if the patient comes to neurology and the pain clinics. Occipital neuralgia is still finding its way in using Botox, but we'll see how we can combine Botox in occipital neuralgia. Trigeminal neuralgia, I haven't given Botox personally and any patients of trigeminal neuralgia, but still there are techniques that you can access to. Piriformis syndrome is responds very well if you use Botox. Similar cases with pelvic floor pain, post-herpetic neuralgia, tension headache, and the low back pain trigger points. So when we talk about the cervical dystonia with the chronic neck and shoulder pain, it is actually the identifying the target muscles that you want to give Botox to. There are 4 postures that usually patients suffer with when we talk about dystonia: the torti, the laterocollis, the retro, and the anterocollis. If we are not going into the postures much, but if you intervene into sternocleidomastoid, the splenius capitis, the semispinalis capitis, and the levator scapulis and the trapezius, the patients very well responds with the Botox medications. So these are the some of the postures that I have pictured this in, and many of our must be well versed with using it. So we go straight up to how to use the Botox in these conditions. So in sternocleidomastoid, it's quite a superficial muscle. It's quite a thick muscle. And if the muscle is dystonic, it is hard, it is spasmodic. You can just pinch the muscle between your thumb and index finger. You don't need an ultrasound for sternocleidomastoid. If you want to use an ultrasound, there's no contraindication. But I usually give in the sternocleidomastoid palpate with the palpatory method, and we ask the patient to turn the head to the contralateral side and inject the Botox into 1, 2, 3 sites, 0.1 ml, or we can go up to 10 to 20 units at one of the point. But the main thing is that you need to preserve your scaliness, and you don't need to touch the clavicular part of the sternocleidomastoid. And you need to take care of your carotid artery and the jugular vein, because you don't want to injure them. It is in very close proximity. Why we are not touching the lower half of the sternocleidomastoid? Because dysphagia is a very common side effect that the patient suffers if you give in the entire sternocleidomastoid. So this was about the sternocleidomastoid. You can also target splenius capitis, levator scapulis, and trapezius. See, the thing is, levator scapulis and the trapezius are very superficial muscles of the head and neck. So you can easily give them Botox, minimum doses 10 to 20 units, zero point 0.1 to 0.2 ml you can give, and the patient responds very well. When it comes to splenius capitis or the semispinalis capitis, they are still the deeper muscles. So there you can use your ultrasound for cross identifying you, or we can say the hybrid technique for identifying these muscles and injecting the Botox. Like in the lower image, you can see how the needle traverses through the in-plane approach, and we can go from the trapezius to the semispinalis capitis and to the obliquus capitis inferior, and finally the drug is given. So this is much safer if you are wanting to go more deeper into the muscles. This is the image I picked up from my ultrasound which I use. It's not that clear, but if you are using ultrasound, a bifid can guide you that you are at the upper border of the sternocleidomastoid, and you can easily inject in that. So I think this was about dystonia, that it gives very good relief when it comes to chronic neck and shoulder pains. The next indication is chronic migraine. FDA has approved its use, but let me tell you, before using in chronic migraine, you should read your anatomy very well. You should know these small muscles, because you don't want to go very deep with the Botox. Just remember the dictum that we don't want to create a functional weakness. This is the preempt injection protocol that we follow in case of using the botulinum toxin. So there is a preempt protocol, there is a follow the pain protocol. The dose is 155 to 195 units. Why 195? Because if you are using Botox, you have a vial of 200 units, right? So we don't waste 40 units if it is consumed. We just inject the Botox into the painful areas as well. See, the cumulative effect thing comes into play. We have to give a trial of 2 treatments at a spacing of 3 months, and 31 sites are usually chosen in this case. We can increase up to 39. The corrugators, procerus frontalis, temporalis, occipitalis, paraspinals, and the trapezius are the muscles that we inject, and these are the recommended doses and the recommended sites that have been dealt with while using Botox. We already know the 0.1 ml, that is the 5 units, is sufficient with a half-inch 30 gauge needle. If you are targeting the paraspinals, you can increase the size of the needle to 1 inch. That will be good. This is a simple pictorial representation I could find of injecting Botox in cases for migraine. Medial end of the brow, the corrugators, both sides. Procerus is a single. The only muscle which receives a single Botox is procerus. You can go for 4 sites in the upper 1/3 of the forehead for frontalis, but you don't want to go very deep into the frontalis, just 1 or 1.5 centimeter depth, because you don't want to create the ptosis, right? Then 8 sites for temporalis, 6 sites for occipitalis, and the 4 site for paraspinal muscle groups, and finally the trapezius. Trapezius is very easy for all of us, because we are giving the trigger points in the trapezius, so that is not of much issue. The thing is when you are giving the temporalis and the occipitalis, that you have to be very careful with. This is the pictorial chart that the preempt injection protocol usually follows. I'm not going into the much details, but this is how we give Botox at these site. Why I mentioned occipitalis? Because it's a very shallow muscle. It's not that deep. So when you give into the occipitalis, you need to be at the not at to be the 90 degree of the skin. You should be at 45 degree and not inject too much of the drug into the occipital area. We are very close to the neck areas as well. So better be superficial rather than going deep. So this is about the cervical paraspinals. Very easy to give into the cervical muscle group. Very superficial muscles given at those 4 points, 2 medial and the 2 1 centimeter lateral to them. So these are the injection sites when it comes about to the chronic migraine. This I deliberately put this image because this was the one failed case which we encountered way back when I was doing my pain course, that this lady when got treated for chronic migraine, and she actually developed these painful bumps over her upper 1/3 of the forehead, which later had accumulations in the subcutaneous plane that was not into the muscle, anything happened, but into the subcutaneous plane, and later was diagnosed as to be post-injection ecchymosis, and settled with a derma opinion, an antibiotic, and ice application. But we had to ultimately terminate the case. We didn't went through with this patient. So it's very important that you should report your if you have failed case or any difficulties in achieving your Botox. A third indication is in cases of limb dystonias. I'm not going into details for limb dystonias, but in cases of cerebral palsy, in cases of Parkinson's, in cases of post-stroke, in cases of post-TBI, the patient often suffers upper limb and the lower limb pain. So there lies our clinical acumen that we can diagnose it to be a case of dystonia-induced pain, and Botox can very easily help in such patients. I have written a case about upper limbs task-specific dystonia, that is a writer's cramp. You may find this in your OPDs, a very painful condition for the person, hampers the quality of life, hampers the writing pattern of the person. You can target the flexors of the muscle, but here also a word of mouth is there. Don't ever target extensor group of muscles. You need to chalk out which responsible for the primary dystonia. You are not actually targeting the compensatory dystonic muscles. The ONA-BOT is efficient, 10 to 20 units per muscles, that is 0.2 to 0.3 ml is sufficient for such muscles, and that is always individualized to avoid your functional weakness. The next indications, not FDA approved, but very used off the label, is the myofascial pain syndrome in cases of neck pain as well as the low back pain. We are very efficient in diagnosing shoulder pain as myofascial pain syndrome, right? We just palpate the taut band, we palpate the trigger point, we see the muscle spasm, we look for the localized pain, we look for the referred pain, and we take the history of the postural trauma or the muscle overload, and we diagnose and label it to be a myofascial pain syndrome. So it's a persistent pain when your pain gets refractory, when the pain is recurrent, when the patient doesn't respond to deconservative management, dry needling, the therapy, the Botox is the thing to go for. ONA-BOT is the answer to this. You can target for the neck pain, you can target the upper trapezius, you can target the levator scapulis. Both are the superficial muscles of the back. Palpatory method is more than enough in injecting 10 to 20 units. You can distribute your Botox to 2 to 4 sites. Actually, the concept of distribution in case of Botox is adopted rather than spread. When we give a steroid, what we do, we say that, or what we do is that we inject the steroid. We can say that we can inject the steroid in a fan-shaped manner, but that doesn't happen with Botox. You cannot give Botox in a fan-shaped manner. You cannot give Botox whatever the number of points be like. So you have to be very specific when using Botox. When it comes to be splenius capitis, you can inject 10 to 20 units or the scaleni. I don't touch scalenus muscles. If at all you want to give, you can use an ultrasound and only go for a scalenus anterior or a medius injection. Never touch a posterior, scalenus posterior. It's very adjacent to major vessels and the jugulars and the carotids, as well as it's a very important accessory muscle of breathing. So we don't want to disrupt that. Then the paraspinals, we'll see a case of lumbar myofascial pain syndrome, where the myofascial trigger points have been targeted about the lumbar myofascial pain syndrome. Now, a word about the EMG. I wanted to point out that EMG can be used. We don't use EMG usually. We are happy with the ultrasound, but if you are using EMG, then just look for end plate noise, just look for local twitch response, and the point where you find these as the highest is their localization for the trigger point, right? This is what we learned from our basic MD classes. So it's not, it looks tedious, it looks different, but you can use EMG targeting your trigger points. It's a very good thing if anybody is using EMG. I don't have an access to using EMG, but using an EMG can be very good. Can we mute someone as okay. For myofascial pain syndrome, who are our candidates? Psychological pain. Many of us have psychological pain. They are not the candidates for Botox at all. Fibromyalgia, you should very well rule out it is a myofascial or a fibromyalgia. You can't giving Botox into the whole body or the focal trigger into the fibromyalgia points. Fixed fibrosis, more than 10 years, I don't think that we can use Botox in such cases. And instant cure. This point I forgot to mention earlier. Botox is never an answer for instant cure. It is not an acute pain service. It is never for an acute pain. It is only used for chronic pain only. Botox can be justified if the pain is chronic, trigger point is confirmed, your modalities have already drained out, then you can use the Botox. This is a zoom out image of what I tried to click from the ultrasound of targeting the trigger point actually. We can see the hypoechoic area within the hypo environment within the upper trapezius. That is actually the localization of the trigger point that we had. And after injecting the appropriate drug, we can see how it dissolves and treats the trigger point after a period of few weeks and days. So this is the what we are usually using, the local anesthetic TPIs. They gives an immediate onset of relief. The duration is days to weeks, can be used in acute flares, low cost, but they don't give a muscle relaxation. They don't reduce sensitization. That is where your Botox can really come into play. Your muscle relaxation is one thing that Botox can add into, and your central and peripheral sensitization reduction is something which Botox has very good advantage at. Sorry. The next indication is occipital neuralgia. We know what is the mechanism of action for Botox, and just the injection protocol I'll be targeting. But trust me, with the occipital neuralgia, it is better to go for a nerve block rather than a Botox, right? If your occipital neuralgia is with accompanied by myofascial contributors, for example, trapezius, splenius, or the semispinalis, that is actually compressing or that is actually spasmodic or tight, and you find that it may be a reason that your greater occipital or the third occipital or the lesser occipital may be getting compressed in its entire path. For example, in case of sternocleidomastoid, as it waves around, it can be getting, with its spasm, it can be getting compressed. Then you need to inject Botox. Otherwise, the nerve blocks are absolutely fine and it works very good in cases of occipital headache, in case of occipital neuralgia. So if you want to inject, then perineural injections are an answer to occipital neuralgias. I am not very well versed with using perineural Botox, but myofascial Botox can be done with minimal dosing, 10 to 20 units. In one sitting, just remember the dictum that don't cross 40 units if you want to inject multiple times in a single muscle. So that is best. 30 to 70 per site is the guideline that is given by the pain societies. But I think 40 is the dead end where you should stop. As you can see, that immediate relief in headache or neuralgias is the ultimate thing for local nerve block. Duration lasts for about a month. It targets nerves only, used for acute flares and the lower cost. While Botox onset, the peak onset will occur after 14 days. So you need to counsel your patient that you will not get an immediate relief. You have to wait for at least a week or 2 weeks. The duration will be 3 months. You need to repeat your Botox after 3 months because of its cumulative effect. Here you are getting targeted the muscle, the nerve, and finally the adjoining structures. So chronic occipital neuralgia, Botox may be an answer. More research should be needed to declare such. Trigeminal neuralgia, I'm usually skipping this slide, but if you have a patient in your OPD, you don't have an access to OT, you don't have an access to your RFA or a percutaneous balloon compression, you can just inject Botox subcutaneously into these peripheral branches of trigeminal nerve. Most commonly the maxillary and the mandibular. These are very commonly used areas like zygomatic, infraorbital, the cheek and lateral to nose. For mandibular, it is the mental foramen, the mandibular border, and the chin or the jawline. So they are very easy areas. There is a separate map that identifies these areas, and you can inject Botox around 20 to 30 units subcutaneously. Though evidence is not that much for using Botox in trigeminal neuralgia, but you can use Botox. And if the patient has associated facial spasms, so you can taper down your baclofen and you can add Botox 10 to 20 units in masseters and temporalis as well. So it helps in the clenching thing, it helps in these facial spasms as well as in the temporomandibular joint dysfunctions as well. This is the chart that actually sums up all the available treatments in cases of trigeminal neuralgia: the drugs, the Botox, the nerve blocks, the microvascular decompressions, the RFAs, and the gamma knife radiosurgeries. So if we talk about Botox, the onset is 2 weeks. It is a minimal invasive procedure, very easy to give. So now you have one thing that you can offer your trigeminal neuralgia patients with, if you don't have an access to your OT setup. This is very important. This is a case, a very commonly case. We found a differential when the patient has a low back pain or a buttock pain, that you find it out to be a piriformis syndrome. So piriformis syndrome is actually a deep gluteal pain syndrome. It causes, when you give a Botox, it reduces the piriformis spasm. It causes its relaxation and improves the function as well. So how you give it? You place the patient prone, you keep a pillow under the pelvis, you keep your hip in neutral. Ultrasound guidance is best when you are giving the Botox in cases of these piriformis syndrome, because you want to safeguard your sciatic nerve. In the belly of the piriformis, it is given. You keep the probe oblique. You approach through an in-plane technique. You can give at 2 to 3 points into the belly of the piriformis. You have your dilutions, and you can give Botox in that way. But this is an important point that the last they have written. I have picked it from an article. They are usually prescribing the Botox for obturators as well, obturator internus, quadratus femoris, and the gluteus as well, because the pathophysiology for piriformis is now changed leaps and bounds. Now they consider it as a deep gluteal pain syndrome. So giving 20 units in your obturators, in your quadratus, and in your glutea is not that bad if your patient is totally not responding to your conventional treatments. These are the ultrasound images I have picked up and labeled as. So when you place your probe, you see your glutea, you see your piriformis, and then deep down you see your sciatic nerve. So it's a window that you get where you put your needle and safeguard your sciatic nerve from getting injured through the Botox, as well as getting injured through the needle. It's a safe injection. We are used to give piriformis a lot, but you can add Botox from now on if you see a refractory piriformis syndrome from it. This is a very important, the last topic, the last indication which I wanted to convey to you all about the low back pain trigger points. See, myofascial low back pain syndrome is not very easy to diagnose, as there are so many differentials clouding it already. You have a discogenic pain, you have a disc herniations, you have a facet arthropathies. So chalking out a myofascial pain syndrome is very quite a thing to do, but we the physiatrists can do it with good acumen, as we are good skilled in our examinations. So what happened with multifidus? It's a very deep muscle of the back. It causes segmental stabilization as well. Sometimes it gets hypertrophied, it gets fatigued in cases of chronic low back pain patients. It has those small trigger points inside it, along with the quadratus lumborum, which is much above than or much lateral to as compared to when it comes to multifidus, as well as the erector spinalis. So this is the injection protocol. When we talk about the Onabot, I can share the images. Yeah, these are the pictorial images where we can target the multifidus trigger points. We go with ultrasound in all of the cases. There is the potential space or the window that we can see at the level or between the transverse processes and the facet joints. That in-plane approach is sufficient, where the needle just go through and you can put your Botox into 2 to 3 points. 10 to 20 units is sufficient, though the literature has told about much increased use of Botox for multifidus, but those were totally into the pain articles or into the pain generals. But I personally believe that it's an internal stabilizer, right? Multifidus can't be dealt with multiple Botox injections. You need to keep that very restricted in cases of multifidus. So the level of injection will be L3, L4, L5. The patient will be prone. You can use a curvilinear or a linear probe, also works as well. You identify your paraspinal layers. You keep your probe short axis in the midline. You identify your spinous process. You go laterally. You identify your lamina. You identify your transverse processes. Then you place it into the short axis. Now you are seeing the facet. Now you are seeing the transverse process. That is the point. That is where you need to target and put your Botox 10 to 20 units into the belly of the multifidus. It causes very good relief. So next time, if your patients are getting a refractory, suffering from some refractory low back pain, Botox can be one of the answers, but don't forget to put them on an intense rehab protocol after the injection as well. Always avoid the excessive volume. We don't want to create a spinal weakness in such patients. So these are for chronic low back pain. A dry needling works. Trigger point injections are what we are using these days. Usually gives immediate relief, and the relief is for a month or so. Paraspinals are also an option. Botox is for refractory multifidus trigger point or the myofascial pain syndrome. Medial branch RFA, especially if the patient of myofascial pain is having is accompanied with facet arthropathy, you can go for a medial branch RFA. And if the patient is radicular pain, you go for an epidural steroid in cases of caudal or transforaminal route as suits you. So this sums up the indications where we are using Botox. I think most of the is for the practical purposes rather than theoretical things. I have compiled a table for just telling you all the level of evidence for all the indications when Botox is used. So very high in cases of dystonia. So next time, the neck pain, the shoulder pain, Botox is the choice we can use. It causes very good pain reduction, whether it is a cervical dystonia, whether it is a limb-associated dystonia, the writer's cramp, your cerebral palsies, your Parkinson, your post-stroke, patients respond to Botox very nicely. Trigeminal neuralgia, you can try. I have not any personal experiences using for trigeminal. Occipital, you can go for. Piriformis syndrome is a must-to-do thing using Botox, as it reduces the spasm, relieves very good in the piriformis syndrome pain. Myofascial pain syndrome, you can use Botox, but a word of dictum, if the muscle is deep, always use an EMG or an ultrasound. It's better to be on a safer side when you inject Botox. It's not a steroid that you can spread anywhere. It's a Botox, so you need to be very specific. Same word for low back pain, chronic low back pain, multifidus trigger point. The evidence is moderate. We need more and more researches and more trials to support all these things. So this is all about the Onabot actually. It is all about the type A botulinum toxin, Onabotulinum, that the duration is 3 to 4 months. These are some of the latest research articles I have just dived into and found my lecture help with it. The first is a very pioneering pain management with Botox type A. It's a very good article. You should go through it. Second is a systematic literature review for trigeminal neuralgia. If you want to have a go, you can read it. This is a very good review article that was published in Neuronal Signaling actually, that specifies the role of therapeutic use of Botox when it comes about treating pain. And the last is I took help with the Korean Journal of Pain articles of Botox used in chronic pain management. And this is the RCT that I've seen in using a Botox compared to a placebo. So now we need such type of researches actually, right? Which should be double blinded and can add to evidence as well. A word about incobotulinum. It is much pure, it is lighter. If you are about to start, if you are prepared to give someone Botox tomorrow or in near coming days, you should start with Xeomin actually. It's less immunogenic, it's very purified, it can be stored at room temperature very easily. The duration of efficacy is 3 months, same it enables transport. Cost may be a factor that we have to look into it, but it is the outputs are very good when you use Xeomin. So it's a second generation Botox, very well used nowadays in pain, in the field of pain medicine, and we can use them as well. So these are the emerging areas in the past 3 years that Botox have creeped into. Like intradermal Botox has been used in CRPS, various nerve entrapments. I think Botox is being used for carpal tunnel syndrome, right? I saw someone's Facebook page once these past weeks where he or she used Botox for carpal tunnel syndrome. So you can deal with chronic carpal tunnel with perineural Botox. Daxi is a longer acting formulation that is yet about to come into the market, but its duration of action is actually 6 months. So very promising. Let's see what it offers to all of us. But Botox should be combined with radio frequency, a trigger point, or a PRP or a Prolo. Still very early days to say all of it, but can be combined as the emerging areas are doing into it. Now, this is a very important slide as we should talk about controversies, right? So, diffusion versus spread, I have repeated it so many times that diffusion is what we aim for Botox. We don't aim for a blinded spread with Botox. So, your Botox is diffusing is way better than its spreading. Dilution strategies actually matters according to the clinician's preferences. How much you want to dilute your Botox, what muscles are you injecting in, is for the dilution strategies. You want to use an EMG, you want to use an USG, that is up to the clinician's perspective. USG should be used if you are targeting Botox in some of the critical areas. Toxin resistance is one thing, that is the Botox resistance we popularly known as. We try to switch the type of Botox. We try to give it a gap to just wear off the antibodies. Long-term safety, I haven't come with many articles that talk about long-term safety of Botox. Cost effectiveness is still a debate, that it's really a costly affair, so it should be dealt with the patient, what he or she wants to have it or not. Botox and Dysport conversion ratio, we already know that it is 1:3 when it comes out to be Dysport. It is 1:1 when it comes out to be a Xeomin. So this is my last slide that has a carry home message, as it is a legitimate analgesic tool, isn't it? We can now see that it's not just about wrinkles, it's not just about spasticity, but it's more about dystonia and pain as well. You can use Botox in myofascial pain. You can use Botox in various neuropathic painful conditions as well. It's a safer drug till you know where you are injecting, and identifying the proper muscle is the key for success of your intervention. Thank you.
Thank you so much, Dr. Mohit, for an outstanding and deeply informative session, and your explanation of the mechanism, clinical indications for evidence-based. And there was a real-world application of botulinum toxin A that you have shown here. So this lecture highlighted the expanding indications of the botulinum toxin in the refractory chronic pain. And yes, you have mentioned that botulinum toxin is used in carpal tunnel syndrome. There are, I think, 2 randomized controlled trial and one case series is available on the PubMed indexed journals. So the importance here is also the proper patient selection. So here we are using botulinum toxin, which is going to cause a weakness. It should be approached ethically and the patient selection should be proper. And I think it should be reserved for the refractory cases not responding to the other conventional treatments.
Yeah, actually that's right. And we, the physiatrists, are very well using the testing the muscles accurately. So we know how to use Botox. That is a very good thing.
And also you should also know that there is a difference in dosing pattern of all the Botox. Botulinum toxin, that is Botox is and Dysport, they use different dilutions. and if you are using any other new botulinum toxin, that you should first read about it, that how and how much unit you want to put in the muscle. And
Yes.
then when you are sure about it, then only you go for it, because whatever you give once, it's going to be there for 4 to 6 months. So
Yeah.
be very sure
Actually,
about it first.
that's why the Ona botulism or the type A is better to use rather than using newer molecules. I think so.
Yes, yes. So we have seen that it is a dual benefit, not only reducing spasticity, but also in the chronic pain management. And I think in time there will be lot of indications. We have already seen lot of studies in myofascial pain syndrome. Recently, I was looking in a study there where in the trapezius muscle they used nearly about 100 units of botulinum toxin A.
Right.
So and they reported that it caused the functional weakness. So they should have not gone beyond 40. So there is a need for ongoing research and the refinement in the interventional pain practice. So today sessions have strengthened our confidence in the botulinum toxin into the comprehensive chronic pain management pathways. And I think there are some questions, Dr. Mohit, if you want to answer. There, Dr. Chandanpreet Kaur is asking that for piriformis, do you directly go for Botox as first line only, or in only in refractive cases?
Good evening, ma'am. Actually, Botox is never found a place as first line something when it comes to multimodal pain strategies for chronic pain management. So I am personally using Botox only when it's a chronic case, it's a refractory case. We found a spasm or a tightness in the piriformis, then only we are using the Botox. It's never a first line thing. We keep the patient to the same protocol as you must be dealing with your patients, the conservatives, the steroids, the other modalities. But Botox is the last resort, no doubt about it.
Devashri Jina is asking whether you have any experience with the writer's cramp, as medicines usually help in established cases.
Writer's cramp, I have just seen a single case and injected a single patient, but they do respond. But actually, in writer's cramp, just Botox is not the answer. You need to go for that motor relearning that your therapist will help you with. You need to go for that assistive, the pen modifications and all. Then only your writer's cramp actually resolves, because it's a very chronic, very notorious condition that patient asks for repeated injections of Botox. One patient in neurology OPD at least had Botox 3 to 4 times a year, every year. So that much how he was dependent on Botox. And he's creating nothing but the functional weakness. So you need to find out the primary dystonic muscle, and then you have to give the Botox. So very limited experience I have, but I have seen that you can use it wisely in such cases.
So there is another question where asking that have you ever seen patient complaining about dizziness or loss of imbalance post Botox injection?
No, such side effects, but it may be a side effect when you are giving inadvertently injecting the Botox, much higher unit into the shorter muscles of head and neck, into the lower back. Then patient can complain of a balance dysfunction. I have no personal experience with these side effects. I have encountered side effects like the post-injection pain, the ecchymosis in the forehead. That's it, not the balance dysfunction. It looks something serious which might happen if you are not identifying the proper structures for Botox.
Actually, I also give a lot of Botox, but in spasticity, and I've also never seen any, loss of imbalance.
Loss of
Even
balance is
neither early, not after
like
6 weeks or 1 month. If you
very rare.
properly
Yeah, actually.
remove
Right,
it,
right.
then it will not going to happen. So there is another question whether Botox for burning feet in diabetic neuropathy pain. Any experience?
Never given Botox in diabetic neuropathies. We go with the medications that are advised, that are FDA approved for diabetic neuropathy. Botox doesn't find a place still, when it comes to diabetic neuropathy. But you can give Botox easily if it's a perineural injections. It can reduce the adjoining muscle spasm, or it can reduce your pain because it is very well used in neuropathic pain syndromes as well. But I would like to know if anyone has used Botox in such cases. I have personally no experiences in diabetic neuropathy.
I also never gone for any Botox intervention in this kind of pains.
It's not
So
that
they
we
must
have
utilize
got a
it.
vial, then we'll be using in every condition, right?
Uh,
So we should be very restrictive in FDA approved indications only. Off the label uses can be done, can be did in, we can do in many conditions. We can put Botox in osteoarthritis knee as well, but there is no role in doing all this. So I prefer being on a safer side.
Dr. Preeti Soni is asking that whether there is a role of Botox in severe painful diabetic neuropathy. I personally think yes, there is. There are some studies that shows that it does help, but I have never given it, so I can't say very confidently that it does work. So I have experienced the neural pulmonotherapy in the cases of diabetic neuropathy, uh, where there is a lot of burning sensation. So I think I have given.
Right. Perineural
I have
pulmonotherapy
given.
can be tried.
I have given nearly about 20 to 25 patients perineural pulmonotherapy in the cases of diabetic neuropathy with severe burning cases not responding to the medical treatment. In that cases, I think majority patient, nearly 60 to 70% patients showed significant improvement in their burning sensation, but usually after 2 to 3 weekly sessions.
It's better to go for a sympathetic block for diabetic neuropathy if it's burning and very disabling. It yields better results. It hadn't been compared with Botox yet. So I think that option is way better than using a Botox.
With Dr. Mohit, I think we should now close the session. On behalf of the organizing committee and all participants, I extend my sincere gratitude to our esteemed speaker, Dr. Mohit Kishore Srivastava, for sharing his expertise. And I also share my gratitude to all the attendees for their active participation. So thank you for joining us for this 18th webinar, and we look forward to meeting you in the next academic session. Thank you.
Thank you all.
Thank you, Dr. Mohit.